Hello there, this is Tony Meekum back again. This is going to be part 2 of our dental and craniofacial lecture. We're going to finish up the dental anomalies with regional odontodysplasia, enamel pearls, Talon cusp, Turner's hypoplasia, and congenital syphilis. We're also going to talk about attrition, abrasion, abfraction, erosion, pulp stones and pulpal sclerosis, secondary dentin. And then I just wanted to talk about a few craniofacial anomalies. So we'll talk about cleft lip and palate, Crouzon syndrome, hemifacial microsomia, Treacher Collins, hemifacial hyperplasia, segmental odontamaxillary dysplasia, and then we'll give you a quiz at the end, as we usually do, to see what you've learned. Ooh, I got some sound effects on the next slides, hopefully to help you remember these. This one is affectionately known as ghost teeth, regional odontodysplasia. It's somewhat rare. There's a synonym for it. This only affects a few adjacent teeth in a single quadrant. And it really does look like, and this is a painting where someone painted ghost teeth, and that's really what it looks like. These teeth was just kind of a shell outline. So it could look like one of these other diseases we just talked about, but it only affects a small portion of teeth. Large pulp chambers, thin enamel, and thin dentin. So keep that in mind. All right, here's another one, enamel pearl. This one's pretty common. You'll see this. Just a small enamel globule on typically a molar root. Has a couple of these synonyms here. I think these are pretty outdated, enameloma. But these are going to occur apical to the CEJ. A lot of times in the furcation or around the furcation, you can see these just extending in various places around the roots. So smooth, round enamel density. It could look like calculus, but calculus usually is not as round as you see here. Might look like a pulp stone if it overlaps the pulp. But what's the significance of this? Well, it could make them a lot more prone to periodontal disease. If this is right around the periodontal attachment, obviously more bacteria could get in there. It's going to be tough to clean and could lead to periodontal bone loss and potentially tooth loss if not treated. And here's your little sound and graphic to help you remember. This is kind of like a unicorn horn. It has been rumored that patients that have this have magical powers. Now, maybe it's because I'm starting that rumor now, but it is a rumor. And then here we have Talon cusp. How are you going to remember that one?
Do the chickens have large talons?
Maybe Napoleon Dynamite can help us remember that. That's just an outpouching and hyperplasia of the cingulum of an incisor. And just like with dens evaginatus, that may hold a pulp horn. So if you want to trim down one of these, maybe it's interfering with occlusion. If you're grinding that down, you could expose a pulp horn. So be prepared for that. And because this occurs on cingulums, it's going to occur on any of the incisors. Imaging, it'll just look like a dense layer, an outpouching of enamel that's superimposed on the crown, as we see here. No sound effect for this one, but Turner's hypoplasia is just a localized enamel hypoplasia from infection of a deciduous tooth, the primary predecessor. Sometimes trauma can cause it, so infection or trauma, that's why we have these two graphics here. And really, it can occur anywhere. As you see, it affects both the premolar and molar here, the incisor here. Now, there's a separate thing that can cause enamel hypoplasia during sickness. If someone as a child gets sick when these teeth are developing, that can look similar to that. How do I know this is not that sickness-related hypoplasia? Well, if we're that, it would be bilateral. You would see the same thing in tooth 25 as you do in 24. So this is just localized to the one tooth. So that means that there was an infection or trauma just to that area, so it only affected 24 in this case. So you're going to need to pay attention to that for your differential. Let's talk about congenital syphilis as well. And so this is direct infection of the tooth by the syphilic spirochete. This can affect the maxillary incisors or the molars. And the incisors get this kind of unique shape called screwdriver crown. There is some hypoplasia of the enamel. And then the molars, they call these mulberry molars. It looks like lobodontia, where there's just multiple molars instead of the normal development of molars like you would expect to see. It's just kind of rounded and lobulated on the occlusal surface. So typically the permanent incisors and first molars. And these first molars may be undersized and constricted in the occlusal third. As another side note, and the most amazing of coincidences, look how close this asteroid came to hitting this visitor center. All right, attrition is a term for when it's physiological wear of dentin. What do I mean by physiologic versus not? Well, here's a sound effect for you if you can hear that. Physiologic is normal wear, so chewing, grinding, eating food. In fact, diet abrasiveness may help contribute to this, but physiologic means it's wearing against other teeth. So bruxism can become pathologic. So flattened cusps, reduced pulp, As the reparative dentin starts to lay down more pulp underneath, you would think there'd be a pulp exposure here, but this has developed so slowly over time that pulp has had time to recede from the reparative dentin laid down. So identify these ones, common in bruxers. This is a really common thing you're going to see. You got to identify and hopefully help the patient stop doing whatever's contributing to the attrition. Now let's contrast that with abrasion, which is non-physiologic wear. There's a sound effect for you, indicating that it's non-physiologic. So probably don't have a metal grinder grinding your teeth, but toothbrush, floss injury, sometimes smoke, holding objects in your teeth, denture clasps can really do it. If someone chews on a pencil or pen habitually, that could wear down the teeth, and that would be termed abrasion. So anything that's non-physiologic but is physical, something physical causing it. That's going to look like cervical notching, especially over-anxious flossing can do that. That's what it looks like occurred here. This looks more like it's a denture clasp that caused it. All right, then what about erosion? What do we mean by that? There's sound effect for you. It's supposed to sound like acid dissolving something. But that's a chemical wear. Acid, so vomit, reflux. If someone has reflux, a lot of times this can happen. Maybe their diet or occupational exposure. And so whatever teeth it affects, and it's going to cause this smooth, glistening depressions. Sometimes it's sharpened on one end. And the typical appearance you get on the maxillary teeth when it's smoothed down like this from the inside, a lot of times that can indicate either reflux or in some cases bulimia. So be on the lookout for that. I feel like this is one that it's a lot better to detect clinically because it has such a smooth, shiny border. You can really appreciate that it's erosion. But on imaging, you will see these defects. It might look similar to bruxism, or you appreciate that it's just one side of the cusps rather than both. Then secondary dentin is dentin deposited in a pulp chamber after primary dentin completes. And so why does this happen? Well, it does happen physiologically just over time with aging. That's one way you can age a patient. You can look and say, okay, these root canals are really narrow. Even though the teeth look full and healthy, the appearance of those root canals being so small and narrow tells me this is an older patient, an elderly patient. It can also occur in response to assault. So here we have some cervical caries, and this should communicate with the pulp. In this case, maybe it has, but in a lot of cases, you'll see that pulp tends to recede as secondary dentin is laid down more. In this case, there should be pulp horns all the way up to here exposed to the oral environment, but this wear has occurred so slowly that secondary dentin was able to be laid down. And some texts will refer to this as tertiary dentin when it's a localized response to a very specific insult, so whether caries or fracture. And so whether you call this secondary or tertiary dentin, I'm not that picky, but just understand the physiological process. And so what do we see here? We see this nice full mesial pulp horn, but where this large distal caries was, the distal pulp horn remineralized. And so that's secondary, or in this case, you may want to call it tertiary dentin laid down. All right, pulp stones. This is just a foci of calcification within the pulp. Really common to see this. Clinically, you're not going to see it, and that's why you got to look at these areas radiographically. These are pretty exaggerated areas. That one's a little more common, but you'll see these pulp stones inside the patient's roots or in the pulp chambers. And then this is really similar, pulpal sclerosis, where instead of just individual stones, it looks more kind of that granular ground glass appearance, but more of a diffuse calcification within the pulp stone. And this really correlates with age. But what's the big takeaway from either pulp stones or pulpal sclerosis? That's going to be a more difficult root canal. It doesn't mean they need root canals necessarily, but if they do need a root canal, more likely you're going to want to refer it or really know what you're doing with having to excavate some of this sclerosis, some of this calcification. All right, that does it with the dental abnormalities. And now we just have a few of these craniofacial anomalies to go through. These are developmental disturbances that affect the growth of the craniofacial structures. Mostly are unknown etiology, but there are some genetic mutations, some environmental factors that can contribute. So abnormality of the shape, the size, the structure, the organization, a lot of different conditions that can affect the face and jaws. We'll focus just on the more common ones. So cleft lip and palate is one you've got to be familiar with. Failure of fusion of some of the facial process. When it's cleft lip and palate, that's medial, nasal, and the maxillary process is failing to fuse. When it's just the cleft palate, that's the lateral palatine shells failing to fuse. So they are kind of different processes. And imaging, you're going to appreciate these defects. Of course, you'll see it clinically as well, and the patient will be aware of it. So in most cases, you're not diagnosing it radiographically, but just to show you what it looks like. These are well defined. There's cortication outlining the defects. That tells you that it's not a recent fracture, not that you would necessarily suspect that. And we see in the 3D view here that well-established cortical outline, but there's a communication through the oral cavity into the nasal cavity. And this one shows bilateral non-fusion of the medial nasal process and the maxillary processes. And so these will have to be treated by a specialized team. It's going to include either plastic surgeon or oral surgeons, speech language pathologists, orthodontists, pediatric dentists, audiologists, ENTs. So a lot of people involved in these, and they'll probably even want to talk to a geneticist. And here's a radiology picture for you, if you ever wanted evidence that carpentry might not be your thing. All right, on to Crouzon syndrome, also called craniofacial dysostosis, not to be confused with cleidocranial dysostosis. But this is premature closure of the cranial sutures. And so the coronal suture closes first, then the rest close prematurely. The unique appearance about this is the beaten metal appearance of the skull, which you might appreciate in cephalometric radiographs. They have shallow orbits. There's maxillary hypoplasia. Pretty rare though, 1 in 25,000 births. Be familiar with hemifacial microsomia. There's a lot of synonyms for this, although I think of this one as more of a specific one dedicated to when it's really involving the ear, because sometimes this does, sometimes it doesn't involve development of the ear and the inner ear structures, the mandible, the maxilla, the zygoma. But this is somewhat common. What you're going to see is a hypoplastic ramus or condyle on the affected side. Here we can see clinically what's going on, really affected the external ear structures and probably the internal ear as well. In this case, on the right side, where's that condyle? It's just missing. Almost the entire ramus is missing as well. Smaller on this side, so everything's kind of shifted toward that left side. In this case as well. Maybe it's the same case, we're just looking at AP view. Everything's shifted to the left, especially the mandible, because it's missing those mandibular structures. And then contrast that with this, hemifacial hyperplasia, where one side just grows more. So half the face grows unusually large. And so you'll see just the opposite. Instead of a missing condyle, one of the condyles and ramus is abnormally large. And sometimes it even affects the tooth size. You can appreciate in that axial slice, even in the 3D view, you have enlarged teeth and bone on that side. In this case, where's the issue? Where it's not as obvious as others. The mandible looks pretty symmetric, but look at the teeth eruption. For the most part, you see premolars only developing the crowns, but over here, these premolars are starting to erupt. So there's accelerated eruption on this side, accelerated growth of those premolars, and that's where the hemifacial hyperplasia is in that case. Then we got our Treacher Collins syndrome, or mandibulofacial dysostosis. The big thing about this is underdeveloped or missing zygomatic bones. That leads to kind of a small, narrow upper face. It also leads to the downslanting palpebral fissures. But they also have mandibular hypoplasia. Could lead to hearing defects. And so look at the shape of this jaw, it's just kind of downward turned. Not much of an angle between the ramus and the body of the mandible. So that's kind of a distinct feature. The missing zygomatic bones are also a distinguishing feature. Gives that downturned eye appearance. Pierre Robin. So this is a triad of wide cleft palate along with mandibular micrognathia and glossoptosis. And so that can lead to airway obstruction. And sometimes this is associated with other syndromes. So just be familiar with that. All right, and then segmental odontomaxillary dysplasia. This one looks a lot like the ghost teeth one, the regional odontodysplasia, where it just affects one area of teeth. But the difference about this one is that it affects the bone as well. There's going to be kind of enlargement of the alveolar process of bone. A lot of times you see these striating lines. So that's what differentiates this from your regional odontodysplasia. See that here? Appreciate kind of these vertical striating lines that you don't typically see. And it's not so much the ghost teeth, right? The teeth are a little malformed. They might be hypoplastic, sometimes unerupted, but it doesn't really look like the ghost teeth. So similar in that it affects just a small location. Oh, another thing that may stand out, they could have ipsilateral hypertrichosis, so extra growth right around the area of where you see this defect. All right, quiz for you now. Which one gives the skull a beaten metal appearance? Remember that one? If you don't, that was the Crouzon syndrome, which has been proposed to develop a third dentition. I moved that into the multifocal opacities, so we talked about that earlier. But that's our cleidocranial dysostosis. What's this one? Do we appreciate what's going on? If you're not sure, look for the arrow. That may help out. We're just missing the ramus and the condyle. And this side, it all looks shifted over to the right. This side all looks smaller. And so that is our what? Hemifacial microsomia. All right, what about this one? Again, kind of a small mandible, but if you saw it affects both sides and it's downturned, so an open anterior bite. Maybe it's hard to appreciate, but it's missing the zygomas, the zygomatic bones. That is our Treacher Collins. What about this one? I'll give you a second to look at that. This one might be tough to identify because nothing really stands out immediately, so look closely at the teeth, and this was the one where most of the premolars aren't even close to erupting, only the crown's developed. But on the upper right, these are developed, so they're larger. There's accelerated development of those premolars. This is your hemifacial hyperplasia, which affects just the right maxilla. So that was a tricky one. And back to maybe previous topics. But what do we have going on here? What's causing this radiolucency? Does that look like a periapical lesion? Maybe just a lateral periapical lesion? Or are the lamina dura intact, and this is more of just a focal osteoporotic marrow defect? All right, and what about this one? It's always better when you have the 3D view. You can appreciate the well-defined corticated outline. It's just a depression from the lingual surface, and it looks like really low density material in here. This is our salivary gland defect, our Staphny defect. Which dental anomaly? What was the first tip? Count the teeth. Here we have canine, incisor, 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 canine. So we're missing a tooth, so that would be what? Gemination or fusion? If you're missing a tooth, it means two tooth germs fused together, and this is our fusion. And then this one you should identify right away. Look at these teeth. They're kind of squarish in shape. Is there enamel there? Maybe hard to appreciate in a pano, but there is really thin enamel, and it's present. The picket-shaped fence teeth. This was one of our amelogenesis imperfecta, and this was the type 1 hypoplastic. Good one to remember. All right, how about this? Immediately you see the constricted roots. You see the constricted cervical area of teeth, sometimes small thin roots, narrow roots, but the bulbous crown is really what tells you this is dentinogenesis imperfecta. If you got that, you just made Samuel Jackson happy. Which anomaly is said to give the patient magical powers? That's our enamel pearl. So when you see a patient with this, you can say it's said to give him magical powers. If they don't believe you, just tell them Tony Meekum, a certified oral radiologist, said it's true, so it must be true. And then closing on this, inspirational quote by Walt Disney, "Whatever you do, do it well." I'll let you read the rest of that. But I'll be back with systemic conditions. See you on that one. Thanks.